Right, let's start. Good afternoon, everybody, if you're on the East Coast, and good morning if you're on the West Coast, or in the middle. My name is Dr. Badr Ratnakaran. You can call me Dr. B. I'm a member of the Lifelong Learning Committee of the ACLP. By profession, I'm the Division Director of Geriatric at Korean Clinic, Virginia Tech Korean School of Medicine. Today's journal club will be based upon the paper on use of Donepezil in treatment for delirium in patients with dementia. And our speaker today is the primary author of this paper, Dr. Ori Lieberman. Dr. Lieberman is a neurology resident at University of California, San Francisco, and the chief resident in neurology at Zuckerberg San Francisco General Hospital. His research focuses on the interaction between systemic organ dysfunction and brain injury during critical illness. And he'll be a neurocritical care fellow at UCSF next year. Congratulations. Dr. Lieberman, the dice is yours.
Thank you so much for having me, and thank you everyone for coming. Please bear with me. I'm actually post-call. I got jeopardized overnight last night, so try to make this as coherent as possible. But I'm excited to kind of review our paper and talk about this interesting part of the intersection between neurology and psychiatry. Let's see. All right. So I will talk a little bit about delirium, dementia, and cholinesterase inhibitors and their role in the intersection between these two clinical syndromes, review our study design and the data set that we used, talk about our findings that donepezil use was associated with improved outcomes in dementia patients with critical illness via a reduction in delirium. I'll review our findings and then talk about some future directions, and I'm happy to answer any questions about our work. So, what is delirium? This is all very familiar to you all, but it's an acute alteration in the level or content of consciousness, plus other cognitive dysfunction. And generally, there are behavioral fluctuations, and phenotypically can be characterized into different subtypes: hypoactive, mixed, and hyperactive. And it's been well demonstrated in the literature that the development of delirium, either before admission to the ICU or hospital or development once in the hospital, is associated with many bad outcomes, including increased mortality, length of mechanical ventilation, ICU and hospital length of stay, and long-term cognitive impairment. The model that we have, or the predominant model that we have for delirium, is that there's a balance between one's predisposition to developing delirium and the precipitating factor and the strength of the precipitating factor. And that balance leads to the manifestation of delirium and encephalopathy. And this same pathophysiology drives the development of any of the potential phenotypes: hypoactive, mixed, and hyperactive. And these phenotypes are not really thought to play a role in kind of the long-term outcomes from delirium. I will point you to a really nice paper published by some of my colleagues here at UCSF, which is a systematic review and meta-analysis of some of the precipitating and predisposing factors in the literature for delirium, but it's things that we encounter every day as neurologists and psychiatrists. And some precipitating factors are, acute brain injury, systemic infection, critical illness itself, kidney injury, respiratory failure, sleep-wake disturbance, and exposure to CNS active drugs. Exposure to these precipitating factors, in whether mild or severe, can precipitate delirium when balanced with a number of predisposing factors. For example, older age, pre-existing cognitive impairment or other neurologic disease, psychiatric disease, or baseline systemic illness such as cardiovascular disease, kidney disease, lung disease, or diabetes. Most current management strategies are focused on minimizing the precipitating factors and optimizing patients in the hospital. But a large area that remains open for study is whether optimizing predisposing factors could prevent the incidence or reduce the severity of delirium once it starts. And this was the question that I set out to address in this study, was whether we could optimize predisposing illness to reduce ICU delirium and its associated adverse outcomes. So how could we begin to test this question? The cholinergic hypothesis of delirium suggests that there is reduced central cholinergic signaling during delirium, and that's caused by any number of systemic triggers that affects basal forebrain function and acetylcholine release or content. One interesting thing is that cognitive impairment, in particular from Alzheimer's dementia, is also associated with reduced cholinergic signaling. And the idea is that patients with Alzheimer's dementia, for example, are at increased risk of developing delirium because they have a baseline lower cholinergic tone. Interestingly, acetylcholinesterase inhibitors, as you probably know, are widely used for the stabilization of cognition in Alzheimer's disease, and there's fairly good evidence for them, and they're pretty well tolerated clinically. Interestingly, in large registry studies, there is a signal for a reduction in cardiovascular events with acetylcholinesterase inhibitors in dementia patients. So one question was whether patients who, let's see, the slide will advance. Okay, sorry. So the question that I asked was whether patients with dementia who were on acetylcholinesterase inhibitors before ICU admission might be at a reduced risk for developing delirium and therefore for the consequence of delirium once they're admitted to the ICU with critical illness. Interestingly, acetylcholinesterase inhibitors have been studied fairly widely, although perhaps not deeply, in the treatment and prevention of delirium. And I actually reviewed this literature in a comment for critical care that you can refer to. But briefly, there have been a number of randomized controlled studies of varying sizes. And in most of these studies, there was no benefit from cholinesterase inhibition, although in almost all of these studies, dementia patients or patients with cognitive impairment were excluded. I'll note that a 2010 paper in The Lancet, which compared rivastigmine, which is another cholinesterase inhibitor besides donepezil, plus haloperidol versus placebo plus haloperidol, had a actually signal for more increased mortality in the rivastigmine plus haloperidol group. But again, these were patients without a pre-existing cognitive impairment, and all patients received standing haloperidol. A large study, 62 adults with pre-existing cognitive impairment and perhaps pre-existing cholinergic deficits, randomized to a rivastigmine patch prior to orthopedic surgery, did show a reduction in postoperative delirium in 2016, suggesting that there may be a signal here. Unfortunately, as you can see here, in critical illness, this is actually quite a challenging thing to study. To prospectively enroll a large number of patients, randomize them to donepezil in the outpatient setting, and then wait for a random event such as critical illness to occur would necessitate a very, very large study population. So one question is whether we could use a retrospective study design to try to generate evidence in support of this hypothesis. To do this, I used the MIMIC database, which is a publicly available database of ICU admissions at Beth Israel Deaconess Medical Center in Boston that has essentially the entire EMR in tabular format, including notes, for all patients between the mid 2000s and 2012 in their ICU, in all of their ICUs. And one major limitation of this study or this database is that they lack pre-admission data. So there's not very good phenotyping of chronic illnesses, but there is some in the notes available from the admission. The benefit of this database is that there's really, really granular data, including medication administration records, all physiologic and waveform data, and then importantly, a subset of, for example, GCS scores or other prospective nursing scores. So what I did in this study was I took the entire database, I looked for patients with dementia and did this using a natural language processing algorithm. Identified patients with dementia, took their index ICU stays. The study population was 2,700 patients, and then split them based on whether they had donepezil listed as a home medication in their chart. And oops, sorry. In this way, there were 450 patients that had donepezil exposure prior to ICU admission, and 2,282 patients that were never documented as being exposed to donepezil. After excluding patients with incomplete data and doing for a complete case analysis, these were our final numbers in each group. Interestingly, the groups were actually fairly well balanced. So again, these are all patients that have dementia, premorbid diagnoses of dementia, and then the group that was exposed to donepezil in the outpatient setting ahead of their critical illness, and then those who were not. The patients exposed to donepezil were slightly older, generally sicker, as you'll see in the next slide, but were admitted to the same kind of ratio of ICUs, including the cardiac ICU, the MICU, SICU, the trauma ICU. There was no difference between patients exposed to donepezil in the early 2000s and the late 2000s here, as you can see. And then, as I mentioned before, patients with donepezil were slightly less sick, although not statistically significant, and were slightly less likely to be mechanically ventilated or require vasopressors, although again, not statistically significant here. Importantly, to perhaps confirm on target effect, as we know, donepezil is associated with reduced heart rate, and patients in the donepezil group had a lower minimum, lower maximum, and lower mean heart rate during the first 24 hours of their ICU stay. Again, perhaps suggesting some on-target effect of the donepezil. So here's the question: does pre-ICU donepezil exposure reduce delirium, or is that associated with reduced delirium prevalence in critically ill patients with dementia? So how can we measure delirium in prospective studies? There are a number of well-validated scoring methods, including popular methods like the confusion assessment method and the method that we use here called the NuDesk score. The CAM scoring in the Mimic database, in this version of the Mimic database, is actually quite sparse. So I used another validated measure called ChartDel, which involves essentially a note text search and validation of all nursing, physician, and rehab service notes in the chart. And with this, you can determine delirium prevalence, but you don't get any temporal specificity, and you don't know whether delirium happened in the hospital or was present on admission. But what I did find was that patients in the donepezil exposed group had a lower, or the odds ratio of, or there was they were at less risk of having delirium with an odds ratio of around 0.72. And after adjustment for baseline characteristics, chronic comorbidities, and illness severity, this remained significant. And then in patients who survived the discharge, which is important to prevent bias against, or essentially if patients come in and die rapidly, then there's not enough time for the delirium to potentially be documented. This effect was the same. Interestingly, in addition to being associated with reduced delirium prevalence, donepezil exposure in these patients was also associated with reduced in-hospital and 90-day mortality, shown here with adjusted odds ratios around 0.7 to 0.8, as well as reduced ICU length of stay, about 15 hours, and then about a 1-day reduction in hospital length of stay. Here's the time to event analysis, and as you can see here, out to 90 days, there is a significant difference in the adjusted Cox proportional hazards model between the donepezil exposed groups and the exposed group and the controls. And then importantly, in critical care, thinking about why there might be a difference in ICU length of stay or mortality. And what you can see here is that in the donepezil exposed group, in patients who were mechanically ventilated, the duration of mechanical ventilation was shorter by quite a significant proportion. And then in many patients, delirium can complicate extubation and lead to reintubation. And the odds ratio for reintubation in these patients was lower in the donepezil group. So what I've shown you here is that donepezil exposure amongst patients with dementia is associated with reduced in-hospital and 90-day mortality, ICU length of stay, and the duration of mechanical ventilation. It's also associated with reduced hospital delirium. And the question is, does the reduction in delirium mediate the relationship or statistically mediate the relationship between donepezil exposure and outcome? And to do this, I used a causal inference technique called causal mediation analysis, which is able to decompose the effects between the exposure, which is donepezil, pre-hospital donepezil, via the direct path directly to outcome, which in this case could be ICU length of stay or the duration of mechanical ventilation, and the indirect path via the mediator, in this case delirium, and the outcome. And in fact, what we found was that there was a significant causally mediated effect via delirium reduction. And this was true across many of the outcomes that I've already shown you, suggesting that delirium reduction mediated a lot of the benefit of donepezil in these patients. Again, here are the conclusions. And we've added here that reduction in delirium at least partially mediates the effect of donepezil exposure on outcomes. There are many limitations of the study, including its single center and retrospective nature, limited pre-hospital record availability, which kind of limited phenotyping of these patients with dementia. Um, Although the in-hospital documentation is actually more robust than one might think. So where are we going with this in the future? We're expanding this retrospective study to multiple centers, and then also proposing that we could repeat some of these ICU-based trials where we would treat with cholinesterase inhibitors, either donepezil or rivastigmine, which had some benefit in patients with a pre-existing cholinergic deficit, either phenotypically, for example, with cognitive impairment or dementia, or with new point of care testing, for example, for acetylcholinesterase activity in the blood, which has been kind of put forward in critically ill patients and associated with a higher risk for delirium. And I'd encourage you to to refer to this paper if people are interested in this potential study design. So with that, I'm happy to take questions and would happy to hear folks' feedback on this work.
Thank you, Dr. Lieberman. Uh, could you give a practical point for practicing consultation-liaison psychiatrist, what you would do in the practice from this study?
Yeah, I think that what I have taken in my practice is that this is just another thing in the bucket of starting donepezil in patients with dementia as outpatients. Um, and I think that it's easy to say, well, I'm not going to start donepezil because patients with dementia are not going to necessarily be noticeably better from it. But I do think that there is reasonable evidence in the literature outside of this study that suggests that there is a stabilization of the slope of cognitive decline, and perhaps from this study, a stabilization or perhaps more resistance to an acute trigger of decompensation with donepezil exposure. So my practice has been to really push for treatment with donepezil in patients with dementia, especially those who might be medically sick, who might be at risk for illness going forward.
Would you also one of the things about treatment of critically ill patients is looking at polypharmacy, and a lot of times you see the practice of stopping medicines that are not as per necessary during that context. And a lot of patients with dementia will be coming with donepezil, and that medicine will be stopped. Would that also be a thought that do not stop the donepezil may
Yeah,
be
so the
helpful?
The donepezil withdrawal syndrome is well documented in the geriatrics literature, predominantly in the outpatient setting. In this cohort, this is actually data that's not in the paper, but in patients who come into the hospital on donepezil as an outpatient who do not have their donepezil continued in the ICU, their outcomes are the worst out of all of these groups. So they're actually far worse than patients who were never on donepezil at all. I think there's a large confounding. Those patients are generally sicker and may not get enteral access and have a much shorter ICU length of stay and die earlier in the hospital. So it's definitely a confounded data set, but perhaps more support for continuing the medication and not stopping it in the hospital.
Dr. Blackwell had a question that she actually sent a direct message to me. Her question was, based on that data set you had, were you able to do any analysis on the benefit of donepezil on any particular types of dementia, like Lewy body or frontotemporal or?
No, unfortunately, the phenotyping of these patients was not fine enough to really do that. Yeah.
Okay.
I see a question in the
Yeah.
Q&A. Yeah.
How long does it take acetylcholinesterase inhibitors take to work at reducing acetylcholine in the brain? Is it possible that the donepezil during the hospital stay is too late to reduce the delirium risk?
The short answer is I have not seen that data. Most of the studies looking at cholinesterase and cholinergic signaling in the brain are using nuclear medicine studies, and those are essentially like steady state outpatients who are on a steady state level of donepezil. So I don't know the answer to that, or I don't know that the answer to that is known.
Another question I think is relevant. I was also trying to come at, is this is by Dr. Tirado. Is this clinically relevant only for patients with delirium superposed on dementia, or is there evidence for use in patients who do not have a dementia diagnosis?
So there is no evidence for use in patients without a dementia diagnosis. I think that In clinical practice, donepezil is not really prescribed for patients without at least mild cognitive impairment. Um, and my study design took advantage of the fact that there would be some kind of random use of donepezil in the outpatient setting, and that would give me two separate groups with potentially different outcomes in the ICU. But donepezil is not because it's not routinely prescribed for non-dementia patients. I'm not sure that I'm able to answer that in a retrospective way.
To my knowledge, and even just looking before this presentation, all the systematic reviews that was done on Donepezil delirium did not find any benefit for patients with a non-dementia diagnosis.
Correct.
Even the ones with dementia diagnosis also were mixed, the systematic reviews per se, but the last review I'm looking at is from 2016, Dr. Thumpy, if I'm correct.
And I think that that was prior to the publication of that final paper with the rivastigmine patch in orthopedic
Best.
patients as well.
Yeah, yeah.
Um,
We have a question by Dr. Hisada. I wonder if there is any selection bias among patients exposed to donepezil, as those with significant medical comorbidities who may not initiate at all in the medicines due to side effects.
For sure. I think that that is a question that's a limitation of this study. There was no difference in a number of different comorbidity scores. I've shown the Elix-Hauser comorbidity score here between the donepezil exposed and the donepezil non-exposed group. But certainly in my practice, for example, patients who have significant cardiac disease or cardiac conduction disease, I'm definitely more hesitant to prescribe donepezil, and certainly could be a bias for sure.
Yeah. Another group I think was not made data may not be available in data set anybody with a GI bleed. Uh, that's one of the side effects of donepezil,
Hmm.
gastric ulcers. Uh, and the stress ulcers can happen in the ICU too.
Yeah.
So that could be one patient group we might exclude. What was any analysis? This is by Dr. Camacho. Any analysis of the dose that was used
Yeah,
in this patient?
the dose in this study was predominantly 5 milligrams daily. There were some patients on 10 milligrams daily, but there was no significant like dose response, suggesting that perhaps 5 milligrams was sufficient.
Right. Audience, any queries? You can type it in the chat box, Q&A. I think for good for the audience of this study design, um, could you tell me more? Could you tell the audience more about the data set you had,
Yes.
the MIC?
Yeah, so the MIMIC data set is a publicly available data set that is de-identified. It's from a single center, but it is the patients are extremely well phenotyped and there's extremely granular data. There are different versions. The one that I used for this study was Mimic 3, which encapsulates all patients admitted to a ICU at Beth Israel in Boston from 2001 to 2012. Mimic 3 has all notes available from the patients, including nursing, rehab services, physician notes, as well as discharge summaries. Mimic 4 encapsulates Mimic 3, so 2001, 2012, and then 2012 through 2019 as well. But it only has de-identified discharge summaries as opposed to all of the notes, but is a more modern data set that is and has many more patients. Um, I've used this study in a number, or sorry, this database in a number of studies. I have found it really helpful, and I think it's really easy to query. There's like kind of options in the cloud as well as local access. And then BI has a process through which, through a website called PhysioNet, I think .org, where you can request access if you have an academic affiliation, and you have to take like some city trainings and stuff like that, but you don't need IRB approval locally to access the data set. Another relevant ICU data set is called the EICU data set, and that is actually a data set of about 200,000 patients that is also operated by PhysioNet. That is multi-center. There are very few patients per center, and it's only a short time frame. I think it's only 2015 and 2016, but it's a nice complementary data set to kind of externally validate findings from Mimic.
Right. So anybody interested in critical care research, this could be one opportunity to utilize that data set. And this is from Beth Israel Decons in
Yes.
Boston. Yeah. Uh, the other study tool used in the study is the ChartDel, which is a retrospective. It's a tool developed by Dr. Inouye. It's a retrospective chart review tool for identifying delirium. It can be a labor-intensive process. So, how did you use that chart for on this data set?
Yeah, so we actually used so the way that ChartDel is initially was initially described was essentially manual review of patient notes and then using a number of criteria and essentially a questionnaire grading patients as having delirium or not. Since then, they've published a number of papers that have essentially used trigger word analyses where charts essentially are searched for a subset of words like encephalopathy, altered mental status, confusion, agitation, hallucinations, etc. And then those charts that go through the initial screen are then pulled out and then are manually reviewed. And using that process, we went through we went through the charts here. And what's interesting is that just using those keywords itself had um, uh, quite a good positive predictive value for having a final Chartdell positive finding in this cohort, even after the like blinded manual review. In a paper I published in Neurocritical Care last year on patients with Parkinson's disease in the Mimic database, I also compared the performance of Chartdell using this approach with CAM ICU and saw a pretty nice correlation. So I think that probably it is definitely labor intensive. I think it provides a complementary information to CAM ICU, for example, and CAM scoring, but is definitely more labor intensive.
If anybody's interested, um, the details of the chart del is available online, but I think you need a license or registration of the tool to use it. Is it
I'm not sure that that's
sure?
true. I think there's a website and
Yeah.
they publish these papers. And in
Yeah.
this paper, I cited all the papers that should
Okay.
be that are relevant. Yeah,
Okay. Because I have used this before for a study, and I just had to ask permission, and they sent me a letter. But that was before COVID, so things must have changed.
yeah. And
Okay.
then I'm also happy people are feel free to reach out to me. My first last name at ucsf.edu is my email, and I'm happy to help people get Chartdel set up or kind of um, work with you all on any of these projects in Mimic, etc. So happy to help in that way.
Uh, any questions from the audience for Dr. Lieberman? This is a very we don't often discuss these kind of study designs using data sets and automating tools, the data sets. So if anybody has any questions, or you can feel free to reach out to Dr. Lieberman later on. Um, we
And then
have one, yeah.
I'll just say I see Dr. Zabinski in the attendees
Oh
list.
yeah,
He was the senior author on this paper and a mentor through this project, and just wanted to thank him as well for.
yeah, yes, Dr. Zabinski, thank you for joining too. Uh, yeah, we have 1 more minute, so we can shoot one more question if you want to, uh, or we can call it a day. All right. So I think we can let everybody be. Everybody enjoy your day. Stay safe. Dr. Lieberman, thank you for giving your presentation for our association or our academy.
Yeah.
We look forward to seeing more of your work, and all the best for your fellowship. And thank
Thank
you
you so
everybody
much.
for joining.